Hello. Okay. First of all, I'd like to welcome all. Thank you all for attendance. And I'd like also to welcome all to the first wave of LEAD, this scientific activity, which means learn, earn, and drive of IBD. And this is sponsored by Johnson Company. And thank you for Johnson to invite me to moderate this session. Actually, it is a very good idea to have a continuous awareness about this item, which is namely IBD. We'll start with Crohn's disease today. And this will be in the form of two talks. The first talk will be by Professor Sushila Dalal, and the second is by Professor Hany Shehab. It will discuss the Crohn's disease diagnosis and treatment. And actually, I think there is a rising incidence in the last few years for Crohn's disease in particular, and generally for the IBD, maybe because of the increased awareness and of some sort of well diagnosis of Crohn's disease. And actually, I'd like to thank also the immunology department of Johnson, because they have a continuous medical education about this item. Now I'll invite Professor Sushila Dalal. She is Assistant Professor of Medicine, Inflammatory Bowel Disease Center in Chicago University, USA. And she will talk with us about how to diagnose Crohn's disease patients. Okay, please.
Hello, and thank you for having me. I'm Dr. Sushila Dalal, an Assistant Professor of Medicine at the University of Chicago, Section of Gastroenterology, Hepatology, and Nutrition. I'll be speaking with you today on how to diagnose Crohn's disease patients. So first, we'll start with what are the inflammatory bowel diseases? Crohn's disease and ulcerative colitis are immune-mediated conditions in which a dysregulated immune response.
Hello.
Hello, and thank you for having me. I'm Dr. Sushila Dalal, an assistant.
Please share the slides, please. Share the screen. Yes, now the screen is shared now.
Professor of Medicine at the University of Chicago, Section of Gastroenterology, Hepatology, and Nutrition. I'll be speaking with you today on how to diagnose Crohn's disease patients. So first, we'll start with what are the inflammatory bowel diseases? Crohn's disease and ulcerative colitis are immune-mediated conditions in which a dysregulated immune response causes damage to the intestine. The immune response occurs as a response to environmental triggers, such as changes to the microbiome in genetically susceptible hosts. We'll focus on Crohn's disease in this talk. So what is Crohn's disease? It's many things, and probably even saying that it's one thing isn't really correct, because it really depends on where the disease is located. Crohn's disease can be inflammation anywhere from the mouth down to the anus. However, it falls into several sort of common categories that we can see illustrated here. Very common is inflammation in the terminal ileum. A lot of the lymphoid tissue in the small bowel is found in this area, and this is a very common location to find Crohn's disease. Crohn's disease, of course, can occur in the colon as well. However, it's distinguished from ulcerative colitis because of its patchiness. Unlike ulcerative colitis, which is continuous and circumferential, starting in the rectum and extending upwards through the colon, Crohn's disease is patchy and may spare the rectum. Crohn's can occur in both the ileum and the colon in this patchy manner we see here. It can be in the upper GI tract. This is a more rare manifestation, but it can occur in the esophagus and in the stomach. Or, unfortunately, you can have people that really have very diffuse disease and have inflammation in the esophagus and the stomach, the small bowel, as well as the colon. So we think about Crohn's disease in terms of where in the body is it affecting, where is the inflammation located, and then we also think about how does it behave, because there's many manners in which the Crohn's disease inflammation can occur. It can be non-penetrating, non-stricturing, which we see here. So this is mucosal inflammation. It's ulceration in the mucosal lining. However, we know that Crohn's can be full thickness inflammation in the bowel wall and can lead to complications. So complications such as stricturing, when narrowings occur in the small bowel or colon. That often occurs when inflammation has become fibrosis. Unfortunately, this is a challenge for treatment as we don't currently have antifibrotic therapies. Crohn's disease can also be penetrating, in which the inflammation actually goes through the intestinal wall and can cause complications such as abscesses or fistulas. And then one particular area in which it can be penetrating is the perianal area. And oftentimes Crohn's patients at some point will develop perianal disease characterized by perianal abscesses or fistulas. And so when we're thinking about diagnosing Crohn's disease, it's important that we describe these features because this is really going to inform how we treat the patients in the future. There are also many things outside of the intestine that can be associated with Crohn's disease. There can be eye inflammation, such as iritis or uveitis. That can be associated either with the disease activity of the Crohn's or with the underlying genetics. There can be sores in the mouth. There can be an immune-mediated condition of the bile ducts, primary sclerosing cholangitis. There can be joint pain, arthritis is common in our patients, and then there can also be skin manifestations such as erythema nodosum, painful, tender red nodules under the skin, or pyoderma gangrenosum, a sterile ulcerating condition. When do patients get IBD? It's important that we know when they get it so that we know when we should be suspicious and when we should think about trying to diagnose Crohn's. The peak incidence is in young people between age 20 to 40. However, some studies have shown that there may be a second peak in the 6th to 7th decade of life. There's an entity that's described called very early onset IBD that can occur in toddlers and infants, and that's thought to have more of a genetic basis. And IBD really can occur at any age. However, we really think of it most in this age group of 20 to 40. What causes IBD? Well, the short answer is that we don't know, and unfortunately, that's why we don't know how to cure inflammatory bowel disease. But we do think it's this perfect storm of genetic susceptibility, environmental triggers, and an abnormal immune response. Genetics in IBD are complex, so one way we cannot diagnose Crohn's disease is through a gene test. Even if there's multiple family members who have the condition, there's no gene test that can tell us if a patient is going to get Crohn's. There's about 200 genetic locations that are associated with IBD genetic risk. Many of these genes, however, are present in the general population of people that never go on to develop IBD, and therefore we can't test for one of these genetic locations and determine whether someone will get Crohn's disease or not. Actually, the chances of genetically identical twins both having IBD is actually low. It's quite low in ulcerative colitis, about 16 to 18.5%. And in Crohn's disease, it's slightly higher, 35 to 58%. So why is IBD rising around the world? Is it because of changes in our diet? Is it because of the rise of antibiotics? Is it this hygiene hypothesis that our immune system sees less bacteria and therefore is less educated? Or is it because we have better ways to find it and we're thinking about it more and we have all these different modalities that we'll talk about in a few minutes? So what are some thoughts about causes of IBD? So antibiotic use early in life, there's some thought that may predispose patients to IBD. An analysis of several studies show that there's an inverse relationship between breastfeeding and Crohn's disease and ulcerative colitis, so that having had a breastfed baby may be protective against the later development of Crohn's disease. Air pollution may be associated with IBD, and diets high in fiber, adequate levels of zinc and vitamin D might be associated with lower risk of developing the conditions. Use of NSAID medications, ibuprofen, naproxen, these sort of medications also cause ulceration of the GI tract and are thought to also be potential underlying causes of disease. So what are the symptoms of IBD? So first we need to, of course, we see the patient, they tell us what they're feeling. So what are the symptoms? It really depends on where the disease is located. Because Crohn's disease can affect any part of the GI tract, not all Crohn's disease patients are going to have the same symptoms. I think for many patients, they think perhaps they can't have Crohn's disease because they think that inflammatory bowel disease is diarrhea. And weight loss. And sometimes they may not have diarrhea. Maybe they have constipation or an abdominal pain as their only symptom. So we really need to think about where the disease is located and what symptoms that would lead to. So for those patients with esophageal inflammation, it may present as pain with swallowing or difficulty swallowing, or they may describe it to us as really difficult to treat heartburn even. If Crohn's disease affects the stomach, which is more common in the younger pediatric patients, that may present as nausea or abdominal pain. So those may be rather vague symptoms. In the small intestine, which is very common, patients may present with obstructive symptoms alone. So it may be subtle and they may not have an actual bowel obstruction. They may feel full earlier, or they may feel bloated after eating, or they may actually present with an obstruction and have nausea or vomiting, or they may have pain after they're eating. Given that the most common location for Crohn's disease is in the terminal ileum, the pain is often in the right lower quadrant, but it can be in other locations as well. For patients that only have disease in their terminal ileum, these may be their only symptoms. Perhaps they only have bloating and abdominal pain and have one formed bowel movement a day. They don't have diarrhea. And for these patients, coming to diagnosis of Crohn's disease can take longer because especially in a young person who's in their early 20s, they may be dismissed as being anxious or having irritable bowel syndrome or something of the sort. So we do have to have a high index of suspicion, keep it in our minds for patients of the right age population. When Crohn's disease is in the colon, the symptoms are similar to ulcerative colitis with frequent diarrhea. However, since the disease is patchy in Crohn's disease, the rectum is actually often spared. So unlike ulcerative colitis, where the inflammation is the most severe in the rectum, we know that ulcerative colitis is characterized by that severe proctitis, which leads to bleeding and urgency and tenesmus. In Crohn's disease, the rectum is often normal, and the inflammation starts a little bit higher up in the colon, and the inflammation is usually worse in the right colon. So it's possible that while the Crohn's colitis patients may have diarrhea, they may not have blood or mucus in their stool because of their normal rectum. Besides these GI tract focused symptoms, there's other more general sort of constitutional symptoms that can give us clues that we should be thinking about Crohn's disease. Often weight loss occurs. This is a red flag symptom that leads us to know that we need to do further testing and evaluation. Fatigue. Fatigue is actually one of the most difficult to treat symptoms in inflammatory bowel disease, even when we get our patients in remission. Unfortunately, sometimes that fatigue persists. I explain to patients that it's sort of, if you're sick with an infection, you feel bad because your immune system is fighting the infection. But when you have Crohn's disease, your immune system is always active. It's always fighting the intestine in essence. And that sort of always makes you feel bad and fatigued. In children, sometimes they can't tell us about these symptoms, and these symptoms are less clear, and Crohn's disease is diagnosed by their poor growth. Suddenly, they were on a certain growth curve, and they fall off that curve. And that can be one of the first clues that we need to look for Crohn's disease. Once again, I mentioned in the beginning, we also need to think about these extraintestinal manifestations. Someone with recurrent uveitis, or eye inflammation, we could think about, well, could they have Crohn's? Arthritis, of course, arthritis can be common, but also can be seen if you see this constellation of abdominal symptoms, abdominal pain and diarrhea, as well as joint pains. That may be a clue that you should think more about Crohn's. And mouth sores. The mouth is the entry way to the GI tract, so certainly mouth sores can occur as well. So after we've taken this history and we understand these clinical symptoms, what are some of the laboratories that can give us a clue that this could be Crohn's disease inflammation? When we do a complete blood count, we may find anemia. Of course, inflammation in the GI tract is a source of iron loss, so iron deficiency anemia can occur. Or platelets may be elevated due to inflammation, so you may see a thrombocytosis. Markers of inflammation, such as the C-reactive protein or the erythrocyte sedimentation, can be elevated. However, these are not perfect. About 15 to 20% of people with active inflammation don't make C-reactive protein. So a normal CRP does not rule out inflammation. However, when we're going through diagnosis of Crohn's disease, it's helpful to know if someone does have an elevated CRP when they have inflammation, because if they do, this is something that we can follow as we treat them, and we can see that the CRP normalizes as we start treatment. We want to think about vitamin levels. If they have small bowel inflammation, we would have some concern that they may have low levels of iron, vitamin B12, vitamin A, E, zinc, or vitamin D. We look at a metabolic panel for electrolytes. Of course, if they have diarrhea, we may see electrolyte derangements. And liver function testing, in particular, albumin may be low with active inflammation because that intestinal barrier function may be disrupted, leading to protein loss in the stool. A newer test that we've been using is the fecal calprotectin. Calprotectin is a protein that's found in neutrophils, and when there's acute active inflammation, the neutrophils infiltrate the intestinal wall. We can then measure calprotectin in the stool. Calprotectin is a pretty stable protein, so the sample isn't too sensitive. So a patient can collect their stool, and we can measure calprotectin as a measurement of intestinal inflammation. This is much more specific than something like the C-reactive protein. It's really best for colonic inflammation, understandably, because if there's colon inflammation, this is closer to where the stool is collected. This can be a nice way to objectively monitor inflammation as we treat patients, and can be an initial way if we're thinking, is this functional diarrhea, is this irritable bowel syndrome, or can this be Crohn's or ulcerative colitis? The fecal calprotectin stool test can be an initial way to make that distinction. Endoscopy in IBD. So of course, endoscopy is the gold standard method of diagnosing inflammatory bowel disease. We need, there's certain endoscopic features that we look for, as well as histologic features on the biopsies. In addition to using endoscopy for diagnosis, we want to assess mucosal healing after we've started treatment. And after 8 years of disease activity, we want to think about looking for dysplasia or colon cancer. We also use endoscopy to look for postoperative recurrence. So what are the features that we look for on endoscopy? In the colon, Crohn's can be ulcerations. It can be small aphthous ulcerations, or as we see here in these pictures from a patient of mine, you can have these deep bear claw ulcerations in the colon. And you'll see normal mucosa with these intervening ulcers. It's important when you do that initial colonoscopy to take biopsies in each segment of the colon so that you can document which area is involved and which area is not. So characteristics we may look for in the tissue is erythema, decreased vascular pattern due to edema in the bowel wall, ulceration, friability or easy bleeding, are some of the characteristics. Here's an example of Crohn's disease in the terminal ileum. You can see here that there's some ulceration, there's edema and nodularity, and there's erythema. You can also see larger ulcers in this area as well. Double balloon enteroscopy is a type of deep enteroscopy that can go further into the small intestine. So if there's jejunal inflammation or there's more proximal ileal inflammation that we cannot reach with a standard endoscope, there have been developed these longer scopes that use two balloons inflating and deflating to sort of pleat the bowel over the scope so they can go deeper into the bowel. This is a way that If there's a suspicious finding on a CAT scan or MRI that looks like small bowel inflammation, we can try to reach the area to take biopsies and confirm the diagnosis. Pathologic characteristics. I'm not a pathologist. I won't go too deeply into this, but one of the most important things to look for in your pathology report is that there's evidence of active inflammation right now, and that there's also evidence of chronicity, that this has been going on. That there's this, in this picture, we see crypt architectural distortion. This tells us that there's been inflammation that has been coming and going because the crypts are no longer in nice, neat rows, but they're rather distorted, crooked, and in sort of a different pattern, showing that this has been ongoing inflammation. So we need to see both of those characteristics. If there's only active acute inflammation, we need to think about infection, or we need to think about medication effect, and we can't make the diagnosis of Crohn's disease without that chronicity piece. Granulomas are often described in Crohn's disease, but they don't occur in all patients. We don't have to see granulomas on the biopsies in order to make the diagnosis of Crohn's disease. So imaging in inflammatory bowel disease, we use this a lot. X-ray we can use for bowel dilation or perforation. We can use CT scans or MRIs to look for bowel obstruction or perforation, abscesses, fistulas. CT scans or MRIs are also nice because they can actually tell us the length of small bowel involved in inflammation. However, we need to be careful. We don't want to keep radiating our patients with CT scans. Our patients are often young when they're diagnosed, and if we give them a CT scan very frequently, that becomes too much radiation for them. So whenever possible, it's nice to use MRI, which does not expose them to radiation. Ultrasound is used in some places. It can be a quick, non-invasive way to assess bowel wall thickness that doesn't expose the patient to radiation and can be done at the bedside quickly. So it's a very promising way to objectively assess bowel inflammation. Here's an example of a CT scan, a patient of mine, a 30-year-old male with terminal ileal disease. You can see here what's important is that the CT scan is with oral contrast. And you can see here that he has a stricture. He had presented with inflammation, with obstructive symptoms rather. Here is an MRI, actually the same patient on the day after. You can see these very clear images of the bowel. Again, the oral contrast is very important in distending the bowel so we can determine if the bowel wall is thick and we can determine if there's any narrowings. Here we can see that the bowel was a little bit dilated upstream of a stricture. So video capsule endoscopy. Video capsule endoscopy is also a way to diagnose Crohn's disease. However, we need to be careful about it because Crohn's disease patients can often form strictures or narrowings. We don't want the video capsule to get stuck. If it does get stuck, you need to make sure that it passes. You need to get a follow-up x-ray 2 weeks later. If it doesn't pass, you need to extract it, either through double balloon enteroscopy or through surgery. There is something called a patency capsule, which is a dissolvable capsule that can be given to the patient first to make sure that the capsule can pass freely. Do not give a video capsule to anyone with obstructive symptoms, as there would be a high risk of the capsule getting blocked. Here's some of the images that you may see of ulceration in the small bowel that would suggest Crohn's. So in conclusion, Crohn's disease symptoms can vary based on the disease location. Endoscopy with biopsy remains the gold standard for Crohn's disease diagnosis. Imaging, such as a CAT scan or an MRI or even a video capsule, can provide the initial suggestion of disease, and it can also add additional information that we can't tell from endoscopy. It can tell us if the involved area is 15 centimeters or 20 centimeters, 30 centimeters long, and it can also tell us if there's any extraluminal complications, such as an abscess or a fistula. Thank you so much for your attention today.
Thank you very much, Professor Sushila. In fact, Professor Sushila is not online with us directly, so we will keep the questions in the session of questions and answers, and we will answer the question, me and Professor Hany, if he allowed us to ask him to answer. And now I'll invite Professor Hany Shehab, our eminent professor of gastroenterology in Qasr Al-Aini School of Medicine. Professor Hany Shehab will talk with us about Stellara innovation in Crohn's disease. Please, Professor Hany. Professor Hany?
Yes, good evening. Can you hear me well?
Yes.
Okay. So thank you for having me today. It's a pleasure being with all of you. Thank you for Janssen giving me this opportunity. So I will be focusing today on discussing the new results or the new outcomes of patients with Crohn's disease treated by ustekinumab, known to us now by Stelara, which is the trade name. Now, there was a very important recent study that was announced by Dr. Sanborn in the last QEGW just a couple of months ago. So today we'll be quickly analyzing the results from these studies on ustekinumab. These are my disclosures. So basically, before we jump into the results of the ustekinumab, let's just remember what does actually ustekinumab do. This is one of the nice diagrams I found in a review about 2 years ago. So we all know that anti-TNFs work on the macrophages, which are present in this area. Anti-TNFs, they block the tumor necrosis factor alpha, which is an initial part of the inflammatory cascade. And we've been depending on these molecules for several years now. A newer generation of molecules has been working on the blood vessel. It actually doesn't block the inflammation, but it blocks the migration of these T cells and macrophages beyond the blood barrier. So these are namely like natalizumab, vedolizumab, and the other anti-MAdCAM molecules. And finally, our focus today is the anti-interleukin 12 and 23 molecule. So these work on the T cells, and they block the action of the interleukin 23 and interleukin 12 by attaching to the P40 subunits on these interleukins. Now, the really most important one is the interleukin 23, because it has been shown that interleukin 23 has a pivotal role in T cell proliferation in the GIT. So we're talking about increased T cell migration into the colonic mucosa. They increase the formation of interleukin 21 and 22, which are pro-inflammatory. And finally, it decreases the interleukin 10, which is an anti-inflammatory molecule. So we know now, I think most of us, that from the initial 2 pivotal trials of using ustekinumab in Crohn's disease, which were called Unity 1 and Unity 2, one of them focusing on the TNF alpha naive patients, and the other one on the patients who have failed TNF alpha treatment, and they have shown significant improvement in these patients. But the question was, will these results be persistent when you follow these patients for years? Because we've known from our experience with anti-TNF alphas that many of these patients lose their response over time. So this was a really very well-designed study. It's called the Maintenance Unity Study with the long-term extension. And I think it's one of the longest studies following these biologicals in inflammatory bowel disease. So basically, they got all patients who responded in the Unity trial, and they randomized them to either 8 weeks, 12 weeks, every 12 weeks, ustekinumab, or a placebo group. And after the maintenance period of about 32 weeks, they did the unblinding, and those who continued, they were entered into the long-term extension study. And this was followed up to a very impressive 252 weeks to assess the efficacy and 272 weeks to assess the safety of the ustekinumab in these patients. Now, a very important point for all of you to understand and for us to really assess before jumping into the results. Now, this is a very, very long study, about 5 years or more. So as expected, there's a big number of dropouts. You'll find that this number is about 40 to 50%, as it is marked. But this shouldn't really affect our image, because you have to take into account 2 major points. First of all, the number that's really interesting to us, which are the patients who really fail this drug, is not the number of 40 or 46. It's actually this number, the combination of about 12 to 5% or about 20%. Because many other patients who were marked as dropouts In real life, you wouldn't have these problems. This was just due to the nature that these were patients in a clinical trial. So you find that a huge number, they were considered as dropouts, but because they just decided not to continue during the study. They might have continued the medication elsewhere, but they just didn't want to do the follow-up and the regular filling the forms and so on. So this is just a point to keep in mind that not all the patients that are dropouts were actually drug failures, and many of them we do know that they were not drug failures. So let's see the results. So clinical remission. Now, first of all, clinical remission, we're talking about a CDAI score of less than 150. So this is a very stringent criterion. Nevertheless, at 44 weeks, we had about 53% or 50% of the patients maintaining this clinical remission, and a very slow decline up to that by 5 years, you have about 30 to 34% who have a clinical remission. Again, I have to remind you that not all these patients, the remaining 65%, were actually failures. Many of them were excluded just due to, let's say, maybe bureaucratic reasons, because being in a study, due to withdrawing from consent and so on. So the actual number is probably a bit higher than this 35% at 5 years. Now, if we segment it into TNF antagonist naive and TNF antagonist experienced patients, as expected, those who were TNF naive had a better outcome than those who were TNF antagonist failures. Now, the question still remains, and I think it's still an unanswered question: is this fact that these patients did worse, is the fact that they are just more difficult patients, or is the fact that you gave them a TNF alpha first, did this have a deleterious effect and cause a worse effect with ustekinumab? We're still not sure about this point. I'm sure we need well-designed studies to reach this conclusion. But so far, what we know is that TNF antagonist failures do have a worse outcome than those who did take a TNF alpha before. So a very important thing also is the point of clinical remission without steroids. In many other studies, when you focus, they didn't give you this result, but it's a major compounding factor. If you have 50% of your patients in clinical remission, but all of them are on steroids, then this is not what us, the clinicians, want. But thankfully, in this study, they gave us this result, and you show that from those that they announced as in remission, 93% of them were actually in remission without steroids. So this is a point to keep in mind. Now, let's move to another option, which is also a good treatment endpoint, which is clinical response. So clinical response means that the patient has improved. He has a CDAI score that has improved more than 100, or he is actually in remission. So now the results are actually quite impressive. So we have, and this is still an intention to treat analysis. So this result excludes many patients who have actually responded, but who have dropped out, or those who have decided not to continue filling the forms, or for several other reasons are not included, but they are still responding. And despite this being a very stringent method to calculate it, you have about 60% of your patients at 5 years are doing better than how they started with the ustekinumab. And I would say the number is probably a little bit higher if you just remove these more stringent criteria of calculating the dropouts. Again, the reduction in the dose of steroids, this is another way of viewing it, that the average dose of steroid use has been reduced and has maintained this reduced level up to the 252 weeks. Now, if we look at it the other way with the less stringent criteria, which what we call the as observed analysis, or what others call the per protocol analysis. Now, this method, it only looks at patients who you actually see until the end of the study. So whoever dropped out for whatever reason, we just don't give him any regard in this method of calculation. So at this point, they only viewed these patients who continued at the end of the 5 years, who were still attending the clinic in the study. And when they looked at it that way, they found that the clinical remission was in about 90%. Yes, you would say that it's not a very accurate way, but I believe that the actual result is probably somewhere in between the intention to treat and the as observed. It will probably be around this area where you have patients in clinical remission about maybe 60 or 70%. Now, why does ustekinumab have this advantage of being having a long-term effect with and maintaining this result? Is that also in the study they measured the number of patients who had anti-ustekinumab antibodies, and the number was significantly low, only about 5%. And I know from other publications that these antibodies actually were not neutralizing antibodies, so they had no effect on the efficacy of the drug even after 5 years. Now, when you compare this to other biologics, it's a stark difference between ustekinumab and others. In infliximab, now in this publication, these results I think at about 1 or 2 years only. In infliximab, it averages about 30 to 40%, and also less but very high in adalimumab. But ustekinumab was the lowest in having anti-drug antibodies. So this is a very, very important advantage of this new molecule. Now, this also gives us another advantage. Now, when we used infliximab before, for example, we always tended to combine with an immunomodulator to improve the efficacy and to reduce the chance of formation of anti-drug antibodies. But look at this result. In Crohn's disease, these are the patients followed for 92 weeks. There is no difference between patients who did use ustekinumab without immunomodulator or with immunomodulator. So you really don't have to add azathioprine or methotrexate when using ustekinumab. It will not add anything. The same was also observed in ulcerative colitis studies, that adding an immunomodulator did not appear to influence the safety or efficacy of Stelara or ustekinumab, which is a very, very important addition. Now, if you compare it, for example, with infliximab, this was from the SONIC trial, you'll find a stark difference between patients with combined biologic and immunomodulator versus those with only a biologic alone. So really, most of us, what we have been known is combining most patients with an immunomodulator, not just the biologic. Now, safety, of course, this is the last, I think the most important thing. Now, ustekinumab has proved from this very long-term study that there has been no difference between placebo and all groups using ustekinumab, whether in the adverse events, serious adverse events, infections, or serious infections. And I think this was probably quite expected, because we know from the previous experience in rheumatology, where they used ustekinumab, I think over now maybe 8 or 9 years ago, in psoriasis and psoriatic arthritis. Now they made this huge registry called the SOLAR registry, containing about 12,000 patients. A small number of them were actually had a combination of psoriasis and IBD. And in this very large registry, you'll notice that in both malignancy and serious infections, there was no significant increase in adverse events with the use of ustekinumab or Stelara. So this is something, again, that we physicians should be very happy about and confident about when prescribing this medication. These results have been reflected in the updated guidelines of the American College of Gastroenterology and the ECHO also, where both now they have put ustekinumab as a valid first-line biologic option in patients who failed conventional treatment. So we don't have to wait until the patient fails the standard anti-TNFs, for example, and then you try the ustekinumab. It is a valid option. I would say perhaps one of the more favorable ones, especially with the long-term efficacy that you can use as a first option. So in conclusion, this well-designed study, it provides the longest duration of an anti-interleukin 12-23 treatment reported in patients with inflammatory bowel disease. Patients receiving subcutaneous ustekinumab, they generally maintained clinical response and remission throughout the 5 years of follow-up. No new safety signals were observed as expected with this molecule. And it's very important to know that ustekinumab was effective alone with no immunomodulator addition needed. And I think the basic conclusion should be for all of us that we need to shift our view from these new molecules from being experimental or the last resort drugs or things that we don't know well about. We should shift to that these are actually very valid first-line and safe options to use in patients with IBD. Thank you very much. Dr. Khaled, I get back to you.
Thank you very much, Professor Hany. Actually, this is very informative talk about the use of anti-interleukins, which is a growing attitude to treat Crohn's disease, and it gives much solutions for the difficult cases in refractory cases or unresponders to anti-tumor necrosis factor. And I'll invite Professor Hany to be with me to answer the following questions in the next session, as unfortunately Dr. Sushila is not with us online, and we have 15 minutes for the questions and answers, and I have few questions from the attendees. First question is from my dear colleague and my dear Professor Sharif Mgaur. It is about the routine practice. Do you recommend scoring endoscopic finding? Do you use a certain scoring system in Crohn's disease diagnosis? And if so, what score would you recommend? So would you like to answer, Professor Hany, or I'll answer?
Yeah, thank you, sir. Dr. Sharif, thank you for this lovely question. Honored to reply to your question, sir. We always say that we should be using these scores, but we always say again that in real practice, sometimes many of them are really very difficult. Perhaps I think in ulcerative colitis, it's quite simple. We have this very well validated score, which is the Mayo score. And I think this is easy to use, and we should really have in every report in a patient with ulcerative colitis, he should have a Mayo score put there. In Crohn's disease, it's a bit more complex. There has been developed the more simplified version, which is the simplified endoscopic score for Crohn's disease. It is supposed to be simplified, but it's not that simple. You really have to assess, I think, at least 5 segments, and in each segment you put many criteria. It is extremely important if you're going to put this patient in a study and follow him up. But in real life, to be practical, I think I'm being honest. I don't do it for all my patients with Crohn's disease. Maybe I should, but I don't do it so far.
I fully agree with Professor Hany. It is a simplified endoscopic score, but actually we will not find it that simple. That's why we don't clinically or practically use it. I don't know whether Professor Sushila use it or not, but we have another question from the attendees also. Good evening. I want to ask how to differentiate between ileocecal tuberculosis and Crohn's disease. Let me answer this question. Actually, it is a very important question. It is very difficult, and is very crucial to differentiate between tuberculosis and ileocecal tuberculosis and ileocecal Crohn's disease. As you all know, that is very difficult, but in fact, you have some clinical, laboratory, and radiological and endoscopic differentiation between ileocecal tuberculosis and ileocecal Crohn's disease. You can depend on the symptomatology in the form of the toxic symptoms, night fever, and so. The presence of ascites is going with the tuberculosis more. The presence of extraintestinal manifestation, uveitis, and extraintestinal spondyloarthropathies and bioderma gangrenosum is going more with Crohn's disease. But the presence of pulmonary condition like pulmonary tuberculosis is going with ileocecal tuberculosis. This is clinically, from the clinical point of view. But from the laboratory point of view, you can depend on the tuberculin test, but it is sometimes it's not good tested. So you may depend on quantiferon gold or EGRA and the radiological assessment of the pulmonary system. However, radiologically for the abdomen, if you do CT enterography, you may find some differentiation between both ileocecal tuberculosis and ileocecal Crohn's. In the form of, in the ileocecal tuberculosis, you will find the cecum is shrunken and the ileocecal valve is thickened, and the cecum is a little bit more or less conical in shape. And there is matted mesenteric lymph node. But in Crohn's disease, there is fibrofatty proliferation of the lymph nodes with uniform thickening of the ileocecal valve and the ileum as well. Endoscopically, the ulcers of the ileocecal tuberculosis is transverse and rodent-like, and the ileocecal valve is batulous. But in Crohn's disease, you will find the ulcers atlas-like and longitudinal with Coombs sign. as far as we find these, we can differentiate, but sometimes difficult to differentiate. Thank you for the question. The next question, I have a patient has secondary non-responder to infliximab. I think to start ustekinumab, but the patient age is 15 years old. Any information about this, Professor Hany, please?
Well, to my knowledge, probably, I think ustekinumab probably doesn't have approval yet for use in the pediatric or adolescent age in IBD. I'm not sure if this has changed recently, but we do know well that it has been used in psoriasis for a long time. And I know of a few large studies that have been in adolescents. I think one of them called the Cadmus trial, and they have shown that ustekinumab was safe and effective in this adolescent population. And I have read recently a few case series on ustekinumab usage in adolescents too, and it seems to be effective. And I believe it will probably be an effective solution, but you really have to be careful on the approvals where you are working before proceeding on such a treatment, because in the location where you are working, it might still be something experimental that you could need an approval for.
I fully agree with Professor Hany. In fact, I have some young adults. I give maybe 2 or 3 cases ustekinumab. Actually, on my own responsibility, in contact with the immunology team of Johnson.
Yeah.
Actually, it's give good results, but about this is not yet approved, fully approved by the FDA for this younger age. But I think it will get the approval for this one, but I don't know when. Any more questions here? So I have one question for Professor Hany, please. We know all that with the perianal fistula of Crohn's disease, infliximab is the drug of choice. Do you have any recommendation in cases of failure of infliximab, in cases of perianal fistulizing Crohn's, to use ustekinumab, or you have any data about this?
There have been, I think, some publications on a few cases that have shown improvement while using ustekinumab in fistulas, but we still don't have the very solid and heavy data that we had on the infliximab early on, which supported the use of infliximab in fistulas. So if you tell me as a first choice in a patient with a fistula, will you choose which one of them? I think it's still difficult to decide. If a patient has already failed infliximab, I would definitely give a choice for using ustekinumab, perhaps in combination with an immunomodulator in this case, because we know that immunomodulators alone do have an effect in fistulas.
The second question, I'm sorry, Dr. Hany, I'll buzzer you with the question, is do you see ustekinumab is superior to vedolizumab in cases of enteroenteric fistulae or let's see, complicated intestinal Crohn's disease, or they both can be used from the start in the naive patient? If you have a Crohn's disease naive patient with complicated intestinal Crohn's disease, do you recommend to use which the vedolizumab or ustekinumab from the start?
Now, the second part is easy to answer. Definitely, I would use ustekinumab or the newer biologics as a first line in a patient with Crohn's disease, even if it's a complicated case, because we have the data now that supported that it is effective, at least as effective as the older biologics, and it is definitely more durable. So I would definitely use it. Now, there was a question or talk about but perhaps it has a slow onset of action. From my experience, and I think from recent publications, the onset of action is not that slow. We have seen in the publications that have shown that in about 8 weeks, you have a huge number of patients already in remission. So maybe in acute severe ulcerative colitis, maybe it won't be the only option that you used before, but in a case of Crohn's disease, definitely you can wait and use it. Whether there is a superiority of ustekinumab over vedolizumab, I don't think we have any data to support this so far. We don't have any head-to-head trials. The only one we had was vedolizumab versus adalimumab, but we don't have one of ustekinumab against vedolizumab yet. So we hope to see this one day.
Thank you, Dr. Hany. There is a last question from the floor. I'm not a clinician. I'm in Japan. There is a 15-year-old boy who has been diagnosed as Behçet disease. It seems that Crohn's is quite similar. He is being treated with colchicine. Would you have a good advice for treatment?
For Crohn's disease, look, yeah, the differentiation between Behçet's and Crohn's is really quite difficult. I mean, endoscopically, they can be identical. Clinically, they can also be identical. The only way to differentiate is perhaps with doing blood tests and the pathology test that we used to do a long time ago. In the management, it depends. I mean, if he's on colchicine and he's doing well, and by doing well, I mean not just clinically, you really have to, whether it's Behçet's or it is Crohn's, you really have to treat this patient down to the point of having endoscopic healing. So the patient doing well is not sufficient. You have to go inside, have a look. Is he doing well on colchicine, as in he has healing of his ulcers? Then I would say don't escalate anything more. But if not, I'm not sure of the role of ustekinumab in Behçet's. It's something I have to revise.
Yes, and they may tried the anti-tumor growth factor, but actually the ustekinumab is not yet. Thank you, Professor Hany, and we will move now to the our next session, which is hands-on training bowel ultrasound by Dr. Sami Elhenawi. Dr. Sami Elhenawi is a radio diagnosis specialist in Nasser International Hospital. He will talk about the ultrasound, and this is very important actually now. Me, myself, in my practice, I depend on ultrasound in part of diagnosis of Crohn's disease, as well as follow-up and in identification of the remission in junction with other tools to reach the mucosal healing. Please, Professor Sami. Professor Sami.
I am Dr. Sami. I'm going to give a very short presentation about bowel ultrasound in general. Then we are going to demonstrate the technique of the bowel ultrasound on the patient. Firstly, we should know some important points before we proceed to the technique of the examination. We should know some important points about the embryology and the development of the gut to diagnose mid-gut malrotation and to know the retroperitoneal bowel segments before we scan. As the retroperitoneal bowel segments they are fixed in every patient. They are fixed bowel segments in every patient, and we can start our examination with they are landmarks to guide us to reach the cecum, duodenal ileum, and other bowel segments. Secondly, we must recognize the appearance of air in ultrasound and the normal bowel signature. And at last, we are going to demonstrate the technique of the examination. Firstly, we should differentiate between the artifacts of air and the shadow of air and the shadow of stones or hard objects, foreign body, bones in ultrasound. The artifact of air is white. Yes, we can see the artifact of air. That's white. It causes an artifact causing named ring down artifact or a reverberation artifact. Here the shadow is white, and here the shadow is white, and it must be differentiated between the white shadow and the clean shadow. Here is the white shadow of the ear, and here is the white shadow of the stones. That's an appendiculus impacted in the appendix. Posterior to it, there is clean shadow, dense black shadow. That's not the shadow of air. This is the shadow of air, a white shadow. It's very important to differentiate between the two. This is also a fluctuative collection filled with air. This is an air aspect causing a reverberation aspect. It's white. The difference between the shadow of air and the shadow of stones is the shadow of air is white, and the stones and bones is black, jet black. Here is another shadow of air, and this is an appendiculus obstructing the appendix. It's causing clean shadow posterior to it. Here's another examples of how to differentiate between the clean shadow and the white shadow, or some call it dirty shadowing. That's a small bowel loop. There is a foreign body inside the small bowel obstructing the bowel. It's causing dense shadowing. That's not air, that's a foreign body. This is the case of Bolson areas. But that's air. We can compare between both the clean shadow and the dirty shadowing to know how to differentiate between the clean shadow and the dirty shadow of air. Secondly, we are going to talk about the ductal mixture. Ultrasound machines nowadays are so developed that we can get very good images of the bowel, and we can get the to differentiate between the histological layers of the bowel. This is the submucosa from inner to outer. This is submucosa. This is the hyperechoic layer. The hyperechoic layer is a part of submucosa that is a muscularis mucosa, and the hyperechoic layer is the submucosa, and the outer hypoechoic layer is the muscularis propria. It's very important to differentiate to identify the bowel signature, the normal bowel signature, as some diseases causes thickening of certain layers of the bowel, like ulcerative colitis. It's mainly affecting the mucosa. Inflammatory and infectious diseases mostly affect the submucosa and causes submucosal edema. And disease like diverticular disease causes thickening of the outer muscle layer. So when we are going to measure the bowel wall thickness, we should include all the layers in our measurement. This is the comparison between the light microscopic image of a bowel loop. This is a mucosa, and this is a submucosa, and this is a muscular layer. Comparing it with the ultrasound image, the mucosa, the submucosa, and the outer muscular layer. Secondly, we are going to talk about a very important thing, which is the retroperitoneal bowel segments and the intraperitoneal bowel segments. The retroperitoneal bowel segments are fixed to a certain location in the abdomen. We are going to start our examination with, and they are a guide to us to reach other intraperitoneal bowel segments which are mobile and harder to scan. The stomach is an intraperitoneal structure. The duodenum is retroperitoneal. The jejunum and ileum are intraperitoneal. The ascending colon is retroperitoneal. Transverse colon is intraperitoneal. Ascending colon is retroperitoneal. The sigmoid colon is intraperitoneal, and rectum is retroperitoneal. We are going to talk about the bowel rotation, as during the bowel development, the bowel rotates anti-clockwise during its lengthening and development. Rotates anti-clockwise, so that the cecum will be located in the subhepatic region. Then the cecum will descend in the right iliac fossa, which is the most common position of the cecum in most patients. In mid-lateral rotation or non-rotation, this rotation doesn't happen, so that the small bowel, the whole small bowel is located on the right side, and the large bowel is located on the left side. In these patients, the cecum will be located in the left side or in the midline, slightly to the left. So it will be so hard to locate the cecum, the appendix, and internal ileum. So you should keep that in mind. Use that rotation because this is a normal ultrasound image of the sphenoid artery and vein. In a single image, by single image, we can diagnose mid-gut malrotation. We scan the epigastric region and we identify the sphenocytic artery and vein. Normally, the sphenocytic vein is located to the right side of the sphenocytic artery. In mid-gut malrotation, the sphenocytic vein is located to the left side of the sphenocytic artery. So, if I start my bowel scan with a transverse section of the epigastric region to locate the sphenocytic artery and vein, we can diagnose mid-gut malrotation so easily. Here is the case of mid-gut malrotation. The sphenocytic artery is located anterior to the left of the sphenocytic vein is located anterior to the left of the sphenocytic artery. And here is the image of the liver, and the small bowel loops are located to the right side of the abdomen, which is abnormally located. Here is a CT scan of the same patient, showing the whole large bowel is located in the left side, and cecum and the appendix are located in the midline. These patients are prone to an emergency condition called mid-gut bulbous, where the duodenum, sphenocytic vein, and sphenocytic revolves around the sphenocytic artery, and it's a surgical emergency, and it occurs mainly in pediatrics. Here is a case I've just seen around 3 days ago. A 10 years old child complaining of acute abdomen and vomiting. This is an image of the epilepsy showing the sphenocytic vein to the left side of the sphenocytic artery. And this is a tiny image of the duodenum, the sphenocytic artery and vein revolving around the axis of the sphenocytic artery. This is diagnostic of mid-gut bulbous. And this is a Doppler image. The duodenum and the sphenocytic vein are revolving around the axis of sphenocytic artery. These patients are prone to bowel ischemia and perforation as a surgical emergency. We can easily miss if we are not doing the scan in a systematic way. I like to do my scan with the epigastric region and to exclude mid-gut malrotation. The second important thing is that if the rotation stops at this stage, the cecum will be located subhepatic, and in turn, the appendix and the terminal ileum will be subhepatic. So it's a very important thing we should keep in mind to easily identify the terminal ileum and the cecum. I'm going to talk about some points about the technique of the examination. We are going to talk about it on the patient, but it's very important to adjust the frequency and the focus. We must do very good compression. In air-filled bowel, to bypass the air causes shadowing, as I said before, and it will obscure the posterior structure. We can scan from the flanks to bypass the air, and we must manipulate the gain. I'll show it to you in the examination. After I examine the epigastric region, I prepare to start my examination with the right iliac fossa to localize the cecum. The ascending colon is retroperitoneal, so it has a fixed position. So I will use it as a guide to start my examination. That's a normal ultrasound image of the colon. That's the colon. It's filled with air, causing posterior shadowing, white shadowing. Then I proceed to the transverse colon. It has the same appearance. Then I follow it to the descending colon, the same appearance. Then the pelvic colon. The rectum, it's the deep pelvic colon. The rectum, as they are deep in the pelvis, they are very hard to scan, and it's easy to miss any lesion in the rectum or the distal pelvic colon unless we can fill the bladder with water, with urine. So we can use it as an acoustic window to examine the rectum. Then we are going to scan the terminal ileum after we have known the location of the cecum, and we will do a technique called mowing the lawn technique. I'll move the probe in the whole abdomen, upwards and downwards, till I scan the whole small bowel. Firstly, the first part of the duodenum is we can use the gallbladder as a landmark to scan the first part of the duodenum. This is a tiny image of the pylorus and the first part of the duodenum, the second part, and then the third part of the duodenum. This is another image of the third part of the duodenum, which is located between sphenoid artery and the outflow. When we are going to scan the duodenal loops, if we draw an imaginary line between the right hypochondrium and the left iliac fossa, the duodenal loops will be upwards and to the left, and the iliac loops will be downwards and to the right. Here is an image of a duodenal loop collapsed duodenal loop. The duodenal loop is characterized compared to the iliac loops with increased processus circularis, which are the folds of small intestine. This is a duodenal loop filled with fluid, and this is a normal iliac loop, collapsed, empty, and we can see here the bowel signature, the stratification of the bowel layers, and this is these are iliac loops filled with fluid. That's a normal image of the terminal ileum, the cecum, and the appendix. These are normal images of the colon. So how we identify the bowel ultrasound, we must recognize the gut signature, and we can localize the bowel by the air pattern affixed anatomical site. What are we going to comment on? We are going to measure the wall thickness, and if it's thickened, we must say if it's stratified or not, because if it's stratified, that means we can define the bowel layers, and it's not a destructive process. But if it's not stratified, that means it's a destructive process like neoplastic conditions. And if it's stratified, we are going to determine which layer is thick, determine the length of the pathological segment, and we are going to comment about the lumen, the content, like if it's the case of small bowel obstruction, we will demonstrate like Goldstone is, and we should comment about the surrounding pattern emergency, and we are going to do a dynamic assessment of the surface and compression. Ultrasound is very good as it's a live scan, so we can determine the surface, and it's superior to CT and MRI in this point. Here there is a bowel loop. It shows increased bowel thickness, and it shows the preserved stratification. Here we can identify the mucosa, the submucosa, and the outer muscular layer. That means it's an inflammatory condition. There is no destructive process. Unlike here, there is bowel wall thickening, non-uniform and attenuated lumen, and the wall is totally hypoechoic with no identification of the different bowel layers, source of stratification, that and neoplastic processes and adenocarcinoma of the colon. The small intestine, the normal appearance of the ultrasound appearance of small intestine, it has a stratified wall. The normal wall thickness is less than 3 millimeters, and the lumen diameter is less than 3 centimeters. This is a normal image of the small bowel. It's stratified, and the wall thickness is less than 3 millimeters. This is a stratified wall thickening. The bowel wall thickness is more than 3 millimeters, like in inflammatory condition, and this is an increased wall thickness with with loss of stratification, and this is a neoplastic pathology. We should look for the mesenteric vessels in our scan, in our small bowel ultrasound scan, as in inflammatory conditions, the mesenteric arteries are hyperemic and shows increased flow, in contrast to the ischemic etiologies. We can diagnose mesenteric artery occlusion or vein occlusion. As regarding Crohn's disease, we know that Crohn's disease presents with thick lesions. It involves all the layers of the bowel, unlike ulcerative colitis. It shows intestinal and extraintestinal manifestations. what we comment on, we should do a static assessment and the dynamic assessment of the bowel. The static assessment, we are going to comment on the mural thickening and the hyperemia. As in active disease, the bowel loop will show hyperemia. And in the dynamic assessment, we should comment on the peristalsis, and we should check if there is any strictures by assessing the pathological segment and bowel diameters and the peristalsis. The surrounding tissue around the small bowel, we should comment on the mesenteric affection. We will talk about the cleaning fat sign. Mesenteric lymphadenopathy, we should search for interference free fluids if there is an abscess formation, fistulas, and we should comment on the mesenteric arteries. Here is the case of Crohn's disease. We see here the terminal showing stratified bowel thickening. We can see the hypocoat layer, and the hypocoat mucosa. And on Doppler examination, the wall is hyperemic. It's surrounded by an axis. The axis, we diagnose axis by its absence of Doppler flow and by its close contact. Here is the system, and it shows stratified wall thickening with increased Doppler flow. And here we are going to demonstrate the keeping fast sign. This is the bowel loop, this is the mesenteric border, and this is the anti-mesenteric border. The echogenic fat, this is the echogenic fat. In the mesenteric border, it reaches the anti-mesenteric border, and a very specific sign in Crohn's disease. Normally, the mesenteric fat is located only on the mesenteric border. In Crohn's disease, it reaches the anti-mesenteric border. And here is a gross picture of the keeping fat sign. Normally, the bowel should be exposed here. The fat shouldn't be covering it. Here, in the affected segment, the fat reaches from the mesenteric border to the anti-mesenteric border. And here are 3 cases of Crohn's disease showing that sign. Here is the mesenteric border. The fat is creeping into the anti-mesenteric border. In this patient, the affected bowel loop is thickened, and there is a tract connecting the small bowel loop to a collection in between the small bowel loops and the mesentery. It's a blind fistula. That's a fistula tract. The fistula appears as a hypocoat tract coming out from the bowel, opening into an abscess or opening into another bowel segment into a fistula, or opening into the urinary bladder and into the fistula. Here is the same image of the same case. Here is the affected small bowel loop, and here is the fistula tract connecting the small bowel loop to this collection. We are going to sketch Causes Ibd for now. It has the same rule, which is the wall must be stratified. Here is a case of ulcerative colitis. The wall is thickened and it's hyperemic. That's the descending colon. Here is the outer muscular layer. That's the submucosa, and that's the mucosa. The mucosa is thickened and irregular due to ulcerations. That's the difference between the normal ultrasound image of the colon and the image of ulcerative colitis. Here the mucosa shows normal thickness, and here the mucosa shows increased thickness, and those are the gross images. I'm going to go so fast about intestinal obstruction. In intestinal obstruction, the small bowel will exceed 3 centimeters in diameter. We are going to measure the diameter this way. That is the bowel wall, and that is the lumen filled with fluid. That's a jejunal loop as the plica circularis is increased in number. That's any image of small bowel obstruction surrounded by fluid, dilated jejunal loop surrounded by fluid. There is another same image to assess the perception. Here the internal contents are moving to and fro, which denotes small bowel obstruction. Another image of small bowel obstruction. Here the internal contents are moving to and fro. That's a case of partial small bowel obstruction caused by an inflammatory bowel loop. Here the bowel loop, the jejunal loop, is thickened, stratified, showing preserved stratification, and proximally the small bowel is dilated. In this case, I show the importance of assessing the peristalsis, as this patient is not complaining of complete obstruction, as it shows preserved peristalsis, and the small bowel content is moving in one direction. Here is another case of small bowel obstruction, but in this time it's complete small bowel obstruction post-appendectomy. Here is a transition point where the small bowel is constricted, proximally it's dilated. Here is a jejunal loop, shows increased diameter. The proximal bowel shows to and fro moving to its contents. And here is the region of the constriction. We should comment also on in any case showing small bowel wall thickening, we should check the mesteric vessels. As in this case, we found that the spheric vein is totally occluded. This is a case of spheric vein occlusion. And we should comment on hernial orthosis, as they are the most common cause of one of the most common causes of small bowel obstruction. That's its ultrasound appearance. This is a defect of the hernia, and the content is bowel. There is a same image of an irreducible hernia containing bowel loops. That's a small bowel reservoir. It's causing small bowel obstruction. Here we can identify that this is a foreign body by the posterior dense shadowing. That's not the shadow of air. It's a foreign body. Just the gross specimen. One of the causes of small bowel obstruction also is ascariasis. One of the causes of small bowel wall thickening is vasculitis. Here we can see the small bowel wall is thickened, the mucosa, which is hyperochoic, the submucosa is hypoechoic and edematous. The plitis circularis are edematous. This is caused by submucosal hemorrhage. That's the normal image of the jejunum. The plitis circularis are thin. Here they are thick and show small submucosal. There are warning signs in small bowel obstruction we should keep in mind, which is the presence of or absence of thick fluid. If the bowel wall thickness is more than 4 millimeters, it's a warning sign of bowel ischemia, and decreased peristalsis or peristalsis in a previously hyperactive bowel. The last thing I'm going to talk about is the intersection. It's very important to know that in intersection in adults should have a leading cause. So if you diagnose an intersection in adults, you should search for a leading cause. Here in this case, it was a 50 years old male complaining of Crohn's disease. Here is a small bowel that's ileum surrounded by echogenic fat. It's endocyanated into the colon. That's intersection. That's an image of the appendix, the fetum, which shows bowel wall thickening, the terminal ileum, and this is the region of the intersection. Here is the leading point of the intersection, shows and hypohot mass non-stratified if we compare between the normal stratified wall and the abnormal bowel segment. Here, if the bowel segment is the bowel wall is not stratified and thick, which raises suspicion of a neoplastic etiology. This is the colonoscopy image of the same patient. That's the leading point of the intersection, which was surgically removed and proven to be a terminal area adenocarcinoma, complicating long-standing Crohn's disease, complicated by ileocecal intersection. Another case of intersection in an adult, showing a leading point, that's a mass in the small bowel causing the intersection, which was proved to be small bowel gastrointestinal stromal tumor. There is a benign entity we should keep in mind, which is called transient benign small bowel intersection. Not every intersection is surgically managed. Some intersections resolve continuously, which are small bowel intersections, vaginal or ileoileal. The small bowel affected segment is short and it shows peristalsis. It doesn't show surrounding fluid. So when we see that type of intersection, we should manage the patient conservatively, and it's not surgically managed. And that's the difference between the surgically managed intersection and transient small bowel intersection. I'm going to talk about the pitfall during my scan, which is a mesenteric pulse, and not to confuse it with the stratified pattern of the small bowel. And we should not confuse between peritoneal abscesses or collections and dilated small bowel. The collection or abscess will form acute angle with the surrounding. The bowel never form an acute angle with the surrounding. This acute angle is never formed by a bowel. So this is not about dilated bowel loop. This is a peritoneal collection. This is another image of a peritoneal abscess. Another image of peritoneal abscess and an affected surrounding bowel loop. Thank you. We are going now to demonstrate the technique of the examination. We are going now to demonstrate the technique of the bowel ultrasound examination. Firstly, we should ask the patient to relax his abdomen as much as he can. And I prefer to start with the convex probe in the epigastric region to identify the sphenocytic artery and vein. Then I start the examination with the right lumbar region to identify the colon and trace the colon downwards till I reach the region of the cecum and the terminal ileum. Then I proceed with my examination. Now I localize the important anatomical sites of the bowel. Then I scan the jejunum here in the left hypochondral region, and the ileum here in the right iliac fossa region. We are going to switch to the ultrasound image. That's the epigastric region. We can see here the superior mesenteric artery and vein. Here the artery is located on the left side, and the vein is located on the right side, which is the normal orientation of the bowel. So we are going to search for the ascending colon on the right side. Here we can see the ascending colon. That's the ascending colon. We go downwards till we localize the cecum. Here, the gases of the colon we can see, which causes posterior shadowing. When we go downwards, these gases disappear. So this is the location of the cecum and the terminal ileum. That's the region we are going to search for the terminal ileum when we switch to the superficial probe. That's the transverse colon and the stomach. That's an image of the descending colon filled with gas. So we are going to switch to the superficial probe.
Dr. Sami?
Yes.
Hello,
Yes,
Dr. Sami?
Yes, yes. Yes.
مع حضرتك دكتور خالد حمدي. Dr. Sami, would you like some preparation, certain preparation for the patient before you're going to do this intestinal ultrasound?
Yes, yes. It's preferred that the patient will be fasting for 6 hours, 6 to 8 hours. The patient should drink plenty of
Just
water.
fasting?
Yes, fasting and drinking plenty of water. So we can distend the small bowel with water, and it will be easier for us to scan.
Yes.
Yes, we should do, during the scan, we should do proper compression to get the bowel nearer to the probe, so we get a clearer image of the bowel. Here, that's the ascending colon.
We lost, we don't have the image, Professor Sami.
Can we get the image, please? The ultrasound image. Can you see it now?
Not yet.
Is it okay now?
No, we don't have the image, you know. The sonographic image is not clear, not apparent.
We are going to, so firstly, we are going to scan the descending colon. the descending colon is fixed in the right lumbar region. We go downwards till we reach the cecum and the terminal ileum. When we reach the cecum, we can identify the terminal ileum and the appendix. When we finish the scan here, we should do the mowing the bone technique and move the probe in the whole abdomen of the patient to scan the rest of the small bowel.
There is a question from the audience, Dr. Sami.
Okay.
Which probe do you recommend to use in bowel scanning?
Yes, we should start firstly with the convex probe. This helps us in localizing the different bowel segments. Then, when we localize the cecum with the convex probe, we should switch to the superficial linear probe to give a better detail of the bowel. Is the ultrasound image okay now?
No, not yet. Another question, Dr. Sami.
Okay.
How accurate is the ultrasound in diagnosis of IBD?
Yes, ultrasound can diagnose Crohn's disease in undiagnosed patients very accurately if the scan is done properly, and it has a very important role in follow-up of the patient of Crohn's disease, follow-up of the treatment and assessing the treatment in active disease or treated disease.
Question is another question from the same one. Can it replace CT?
Yes, CT is very accurate in the diagnosis of Crohn's disease, but ultrasound is safe and can be repeatable. It has no radiation, and we can use it in assessment of the dynamic assessment of the bowel, like strictures. CT will not be able to demonstrate strictures like inflammatory or fibrotic strictures of Crohn's disease. Ultrasound can diagnose strictures very easily, as we are going to assess the peristalsis. So,
do you use elastography in assessing fibrotic stricture?
We can use the contrast-enhanced ultrasound. Contrast-enhanced ultrasound can differentiate between fibrotic strictures and inflammatory strictures. In inflammatory strictures, the bowel will demonstrate increased blood flow in contrast to fibrotic strictures.
Yes. Another question from Professor Sharif Mgawar. There is a specific ultrasound features of diverticular disease of the colon?
Yes, of course. Diverticular disease, ultrasound is very sensitive in the diagnosis of diverticular disease, as you are going to scan the region of most tenderness in the patient's abdomen pointed by the patient. The colon will show increased wall thickness, stratified wall thickness. The diverticulum will be demonstrated very well in ultrasonography. It's like an outpouching arising from the outer layer of the colon, surrounded by inflamed fat, and by Doppler examination there will be hyperemia. And ultrasound can demonstrate the complication of diverticular disease, diverticulitis, and diverticular abscess. But in air-filled abscesses and complicated diverticular disease, CT is far more superior than ultrasound. Is the ultrasound image okay now?
Now, yes, it's okay.
Yes. Okay. We are going to get an ultrasound image of the terminal ileum. That's the cecum, and that's the terminal ileum going to the ileocecal valve. It's filled with air, and the wall can be measured this way. That's a normal wall thickness of 2 millimeters. Those are normal images of the jejunum. We are scanning the left hypochondrium. Here the bowel is filled with air. And those are the mesenteric folds of the bowel. We shouldn't confuse the appearance of the mesenteric folds with the normal stratified appearance of the bowel. That's a normal image of the pelvic column. It's filled with air, showing the colonic haustra. We are scanning now the left iliac fossa. And that's a normal image of the descending colon. And that's the wall of the colon. And measure it now. It measures 3 millimeters. So that's all about the ultrasound scanning technique. We should remember that we should prepare the patient well. We do a very good compression. We should localize the different bowel segments, the retrocutaneous portions of the bowel segments, which are fixed in location, which will guide us to the rest of the important landmarks of the bowels, like the terminal ileum and the rest of the bowel segment. Thank you.
Thank you, Dr. Sami, for your very informative talk about the ultrasound in IBD. And actually, we have a very good knowledge about ultrasound in cases of diagnosis and follow-up of Crohn's disease in particular, and in IBD in general. And actually, as you just mentioned, we can use ultrasound in follow-up for the patient as well as in diagnosis, and with less cost and less, more or less, exposure to radiology. And I have a patient, pregnant patient with Crohn's disease, was diagnosed in pregnancy by ultrasound together with the biomarkers. In fact, it is of a great value also to define the stricture, whether inflammatory or it is in the stage of fibrosis. And I remember a case we have, I would like to ask you about it also. We have a patient referred to surgery because we have recurrent attacks of subacute obstruction. And when we do the ultrasound, we found something called fecalization of the jejunum.
Yes.
They found a stricture and a solid stool matter on top or above this stricture, which denotes that there is something going on. And actually, we shouldn't find solid material inside the jejunum. It's usually a liquid matter.
Yes.
So fecalization is the presence of some sort of solid fecal material that denotes a stagnation in this area. Is it like this or not?
Yes, you are talking about the strictures. Yes, it's we will find the affected bowel segment proximal to it. The small bowel will be dilated. the processes will be decreased, and as you said, it will produce fecalization. Fecalization is a fecal hard matter inside the small bowel, causing posterior dense shadowing, which is not normally seen in the small bowel.
Okay, there is another question for you, Dr. Sami. Does ultrasound help in early disease? I think we answered this question, but if you want to add anything.
In early disease, we will find the earliest sign in ultrasound we can see is increased wall thickness and hyperemia. It's not specific to Crohn's disease in particular. It can occur in other infectious or inflammatory diseases like infectious enterocolitis. It's not specific to Crohn's disease in early disease, but ultrasound is in particular very informative in follow-up of non-Crohn's patients.
Okay, thank you, Dr. Sami. There are some questions for Professor Hany. Are you with us, Professor Hany?
Yes, I'm with you, sir. Please go ahead.
Yes, there are two repeated questions about when to stop the biologics and when we have to stop the maintenance treatment with biologics in cases of Crohn's disease.
Yes, it's a very important question, and I think it's a question we all really want to know the answer about, because it has become difficult to maintain these patients for years now on biologics. Part of it is due to that we are afraid of the side effects. Part of it is due to the cost. But unfortunately, so far, we don't have an answer when to stop. The basic answer is you shouldn't stop. You should continue on biologics as long as the patient is doing well. There is an ongoing large study called the Recycle Bio study. It's run by the European Union. They are seeing which patients, or what are the predictive factors that you find in a patient that can tell if he can actually stop or not. We still don't have the full results of them, but I think in the last UEG, Dr. Vermeer gave us like a sort of idea and said the results were not good. That probably until now we still cannot stop biologics for most of our patients. You can, if you have to, perhaps if you have a patient who has complete mucosal healing for at least a year, maybe you can try, but there is no evidence to support that this patient will not relapse, unfortunately.
Okay, thank you, Professor Hany. There is another question from Dr. Abdullah Al Musa. After a start of ustekinumab, when should be evaluating the patient endoscopically? And if patient has partial response, what's your advice? Short duration or increase the dose?
Again, very important question. Usually, we don't rush with the endoscopic follow-up. It's one of the latter endpoints that we used to follow. This patient I would follow very early with a fecal calprotectin, and of course clinically and with the other biomarkers like CRP. And but the endoscopy, I would wait until 6 months to do an endoscopic follow-up. The question is, if the patient is still not fully responsive, whether to decrease the duration or increase the dose. I don't think we have any study that said this or this was superior to the other. I would favor decreasing the duration, but this is only based on a personal preference, but not on any scientific data to support it.
Okay, actually, I agree with you. I think there is no study for the increase the dose for ustekinumab, but they have a study already running about the 4 weeks interval in cases of partial responder to the ustekinumab. Another question for Professor Hany. You have a lot of questions, Professor Hany. Does biological treatment help to protect against CRC in patients with UC? Hello? Dr. Hany?
Can you hear me?
Yes, I hear you. This question is, does biologic treatment help to protect against CRC in patients with UC?
I think no, this question, it's a very big question that we can't really answer simply in one statement. The bottom line is we don't have solid evidence that treatment would decrease the risk of CRC, but we know that increasing inflammation is a risk factor for development of CRC, at least in ulcerative colitis. So I think it probably reflects also on Crohn's disease. We don't have the full scientific data to support it, but I think it makes sense.
Yes, I think I also agree with you. If you reach it with your patient to the point of mucosal healing, I think you logically you may help him to avoid CRC, but no data about the value of biologic itself in preventing the development of CRC. Any more questions? I don't think we have any more questions. So I think there's no more questions. I'd like to thank Professor Hany for his elegant talk and his answers. And I'd like also to thank Dr. Sami Elhenawi for his very good overview of the ultrasound used in bowel assessment in cases of IBD. Finally, I'd like to thank Roya Company for organizing this meeting. And thanks again for Johnson to invite me to be a moderator for this meeting. And thank you very much.
Thank you, sir. It's been a pleasure.
Thank you very much.